So this is really to help prevent ALS with this lower lobe.
It's going to help mobilize secretions, and it's going to help pop open the alveoli, which, again, is going to help prevent that lower lobe atelectasis and pneumonia. So we're going to neb and vest together. So we're opening, bronchodilating, thinning secretions, moving them around. And now that we did all that, now that we have all these secretions that we just moved around, that's when the cough assist will come in place. Okay? Some of you may have heard or may have been told insurance companies will not pay for a vest and a cough assist. We don't know why. There are different billing codes. They do different things. But that's an insurance company thing right now that someday will pass.
It's Medicare.
It's not Medicare. Mm-hmm. So what your cough assist does, there's two different cough assists out there that you guys are going to see. This one you'll probably see more so. This one is made by Hillrom, which is the same company that makes the vest. This one is made by Respironics. Okay? Benefits, I don't remember if I told you or not. The Respironics one just came out with an oscillating mode, which is kind of like the vest inside out. Okay? So when a patient breathes in, this one can actually deliver oscillations, jiggling the airways to help mobilizing the secretion.
So with that, if this new piece of equipment's ordered, they don't need the vest. You don't need to fight with insurance to get both.
I'm just going to do that Respironics T70 and you got it.
Will accomplish both.
Exactly. And the Respironics one, I could set 3 different prescriptions with it as well. So we can set it for an oscillating mode for when we have secretions and we really need to work it. We could set it for regular cough assist mode, which I'll show you in a moment. A lot of times I'll set my 3rd prescription on just an exhale for patients that have issues with swallowing and choking, because if we have a little mucus plug stuck here and we do regular cough assist, I've been told by some of my patients, Sherry, we're kind of fighting the battle here. We're pushing air in, which is going to push that plug down, and then we're trying to pull air up and out, which is, and so you're kind of fighting the battle. So I'll set a 3rd prescription on the exhale only, so a patient can just take their own breath in and then utilize that machine with negative pressure to help bring that mucus plug up. So what a cough assist does, rub it up here. The first, see how it's kind of fluffy? It creates a little bit of a positive pressure. So breathe long. So breath in. Negative pressure, so that breath out. Hyperscan, breath in. Negative pressure, breath out. And they're very loud. So that cough assist delivers a super high positive pressure in to really hyper expand the lungs, and then again it quickly converts over to a negative pressure, simulating a cough to help your patient cough. I recommend your cough assist therapies to be done with a mask. You can do a mouthpiece, but it is very hard to create that good feel. So I like my patients to use a mask, okay, just like this. So that way that air, you're not going to lose it. The air is going to go in, and then tell your patient on the exhale, do your best to cough. Utilize the negative pressure of this, but you still have your patient try to do their little cough with it. Another benefit of cough assist is, of course, blowing your nose is very hard if you have a neuromuscular disease. In order to blow your nose, what do you need to do first? Take a breath in. So I tell my patients, use your cough assist. Take that breath in, and then on the exhale, close your mouth, breathe out of your nose. Worst thing that's going to happen is you're going to get boogers in your mask. No big deal. And then, as Ileane said, every patient with ALS should have a suction machine available and have that ready, because most of the time we're pretty successful with the cough assist for moving secretions around. So you want to do your therapies and suction as needed in between. All right.
Okay, so we're ready for questions and answers. Hopefully answers. Lots of questions. Anybody have questions? Yeah.
I've done quite a few ER visits with positive ALS patients.
Can you speak louder?
I've done quite a few ER visits with ALS patients who have usually like respiratory insufficiency episodes, and the respiratory therapist at hospitals sets a different setting to make it more effective. But then they can't even touch the current work around that. Their own personal
The first thing is to make sure they take their own equipment with them.
They did, but
Or they can't, that's because hospitals use the V60s or the Vision Air, which is going to be a little bit different than our resident machines in the home. Contact your home care company. Ask to speak with the tech or the therapist, because we can at least suggest, okay, we're on this on a ResMed machine. We're using a Res product, so these settings are comparable.
I had trouble even contacting you.
Oh, yeah. The companies should be available 24/7.
If you're using the company that
Which
she's
is
with,
official today, by the way.
is 24/7. Okay, the other thing I might suggest is if it's going to a local community hospital, which doesn't have a clue about ALS, is to make sure the emergency room physician calls the pulmonologist at Northwestern if they're an ALS patient from Northwestern. If they're a U of C patient, I can't take credit for that. But if they're with us, we have 24-hour coverage between our two respiratory pulmonologists, ALS pulmonologists, and their fellows. They all have fellows. So there's 24 hours. So get that emergency room physician or that pulmonologist, if there is one, at that community hospital to call the doctor. The number at Northwestern.
I can answer that question.
Yes.
They we do this and then they make recommendations change to the
Settings.
settings in the home position. The respiratory therapist at hospital cannot touch.
That's right. Correct. Correct.
So how do we facilitate getting changes on the home machine?
Then you call the company that provided that machine to come out at time of discharge.
From the hospital.
Or come into the hospital.
9 times out of 10, they're either being discharged home or work here.
Mm-hmm.
So that therapist should be available to come out to make those changes.
What-
And or a lot of these machines, like your ResMed, okay, that little machine right there, a lot of our machines have modem capabilities. I can make a change at my house on a machine.
Right. This doesn't have to be done in person.
I can just go, oh, we want to do these settings, click, and it sends it over to the machine.
And also at the clinic, if it's during daytime hours, we have someone there who can do those changes electronically,
So is it.
remotely.
Always it.
Always at night.
Along with my fellow take care of 27 campgrounds.
Right.
But every durable medical equipment, especially if they're J-code credited, okay, they should be 24/7.
And the other thing is that our pulmonologist, Dr. Wolf and Dr. Coleman, can talk that emergency room doctor
And the physician can make the changes.
The physician can make the change.
I guess I would probably feel comfortable talking to the physician with change.
Right.
Yeah. They're very easy to change, so I just need to talk to doctor.
Right.
I wouldn't talk to a family member or just, a therapist with a doctor.
And then often if that patient cannot go home or needs to be, we try to get them transferred to Northwestern if they're one of our patients.
I have a friend that's currently battling the disease, and she mentioned something about a stem cell treatment that is just,
Okay. It's not available. Right. It's in clinical trials.
Right.
It's in clinical trials.
Right.
There are 5 centers in the United States that are doing these. We started at Emory. They're in their phase 2 or 3 right now. You have to be local to that geographic area.
Right.
So Atlanta, Georgia,
and I think
Mayo Clinic,
Georgia.
University of Michigan, Cedars-Sinai. I think I've got pretty much.
And what is the goal of this trial? What sort of outcomes are they looking for?
Well, we're waiting to see what the outcomes are right
To
now.
better manage.
To slow the disease. Slow the disease process
Yeah.
down.
Okay.
It's not being promoted as a cure.
Yes.
To slow things
Yeah.
down.
Yeah.
Dr. Mark, what questions? Yes. Radicava, otherwise known as Evardone, if I can pronounce it. Yes. Okay. So that that is a drug, intravenous infusion drug that was clinical drug trials were done in Japan, about 136 patients. So it is to a very fixed society, Asian society. It's now being tested in Korea. Again, it was the first drug ever to get through the FDA without going through clinical trials in the United States. So it came to us, it finally passed Customs and Immigration and came in August. We have patients who have started in October. At Northwestern, we are working first. The first few patients were certain private insurances that approved it. Those patients who tolerated it well, we haven't had any adverse reactions because one of the reasons is the first 24, 23-hour admission is at Northwestern so they can observe the patient and then put the port in. It's a port. Just can't do it, superficial access. So right now, I think we're probably up to 8 patients, 7 or 8 patients, and they go home, and it's a home infusion company that's contracted with the drug company, and it's being tolerated well and being taught to be done at home. Well, so far, we know the benefits from the clinical trial that 33% slowdown of the disease, extremity slowdown. But here, no, too soon. Yeah. Hope that answers. Thank you. Any other questions?
Is there anything you can do about the circulation?
They're benign, pretty much. It's not painful, but some people, muscle relaxation, that kind of thing. But usually it doesn't require much. It's annoying. Yeah. Keeps them up at night. Keeps the loved one up at night. And sometimes it's the loved one, the bed partner, who realizes